As you can see in qualitative, majority of the research is qualitative. All your research, you're doing the numerical number, you do analysis of that numerical number, you look at the patient care. This is in the qualitative. If you read the definition in the books, it's gonna be give you more detail about it. Gain detailed information about the topic, to understand the person's perception, identify the influence of culture, rules, and behavior. In qualitative research, this research usually to improve the quality of standard quality. You're talking about the quality, like take any example in your field about quality. You want to improve that quality, you do what they call it qualitative research. That's in a simple way. I don't want to go in detail because this is not the main topic I'm going to talk about. This is the main topic. We're going to stand here a bit and go in detail. In epidemiological books, you read about study design. They define this design into 4 areas. Either you do descriptive study, you're describing something, and that's under heading of case report, case series, correlation study, or cross-sectional study. We're going to talk about each title of these individually. Then you go to the second category, is called case control study. In case control, whether you go retrospective or prospective. The third group, cohort. Again, cohort could be retrospective or prospective. And the last category, and that's the one people talk about nowadays, about the corona. People talk about clinical trial, or you talk about experimental. Both mean the same, by the way. We're gonna touch every heading in detail now. Study design, in some other book, they have different classification. They said, no, it is either you do experimental or you do observational study. And they define observational to case series, case control, cross-sectional, ecological study, that's something new, you're going to talk about it, and then cohort study. Again, experimental is still the separate category. Experimental, this is the people talk about interventional therapy, interventional vaccine, this is the hot topic today, or interventional procedure. So you are introducing experimental, by the way, meaning you're introducing the new intervention in human. Doesn't mean that you do it in animal, no, it is you introduce something in human, whether treatment, diagnostic, vaccine, procedure, machines, anything introduced in human, it's under experimental testing, and then you go for final approval. Observational study, meaning that the investigator observed the event and the outcome as it happened. So you are doing a retrospective study. You are not the one who did the surgery. You're just reviewing the chart. It's kind of observational study. You can call it retrospective study. You call it retrospective study, or you call it, practically it's an observation study. So the researcher have nothing to do with the study. He's not the one who did the procedure. He's the one who's reviewing and observing the event and document event as it happens. Intervention study, that's something else, that you do the procedure yourself and you are following the result. So I'm doing this cataract procedure. I like to see the patient after 1 year, what happens. I like to see the patient after 6 months, what happened. So you are the one performing the procedure and follow up the consequences of the outcome. Look at the definition in the book. Investigator, allow the exposure, and the follow. Let me just move this here. And the follow subject mean the patient, by the way, or participant. Do you know what's the difference between subject and participant or patient? Their three terminology comes every time and then, and you have to know the difference. Anybody knows the difference between subject and participant and patient? Right. Subject and participant, it might be not a patient, by the way. Suppose in your study, you have control arm a normal and the disease arm is a patient. If I'm going to talk about both group, I cannot say patients. No. If I'm talking about both group, I said participants. because one arm is a normal. So participants usually cover normal and sometimes abnormal. But when you see patient, that means both arms in your study is a patient. So the uses of participant and subject is the same. If I say I have 20 subjects in my study or 20 participants in my study, 10 patient and 10 control. Okay, so don't generalize that I have 40 patients and you have one arm is normal. That's a bit of, when you read it, you have to understand why they didn't put a patient here. So intervention study, investigator, allocate exposure, that means the procedure or your intervention, and follow up subject. That means either, here meaning subject, either patient or a normal participant for development of the outcome. Now, I think Dr. Ahmed give this more in detail, and the case report, it is you're reporting abnormal unique case presentation, usually within 1 to 4, 1 to 5 patients. But make sure that your case report is unique. Most of you guys excited about seeing abnormal case for you. But when you go to the literature, you find hundreds of these case reports being published. So it's not case report anymore. So when you have abnormal presentation or abnormal behavior, you think this is a unique presentation, you think it's a unique patient, please go to the literature, review it. If you find really it is unique, or really it has been only published 1 or 2, maybe, okay, it's acceptable as a case report. To write a case report, I think Dr. Ahmed gave you this session, but it is under category of descriptive study. So descriptive study, one of them is case report. Case series, no. Case series is a group of patients have either similar treatment or similar presentation. Suppose I have a 20 women, or let us say 10 women, talking about the gynae, they all presented with hirsutism. And they all have the same background diagnosis, like polycystic ovary. What I'm going to treat them? I'm going to treat them by this treatment. So the case report or case series now, there are group of patients have similar presentation or have similar treatment because the diagnosis is the same. That's the case series. Another thing in the case series, they have no control. When I'm reporting treatment, I have 20 patients treated with this, I'm saying clomid, one of the gynecological intervention, clomid. Do I have a control? No. So that's considered as a case series because you have treating all your arm. It's one arm patient. You have all treatment, and then you document what's happening, whether improvement or doesn't improve or complication. Since you don't have a control arm, it is fall under category of case series. Okay, no hypothesis testing. I don't know what's going to happen. I'm just presume that they might be improved. So that's another easy case, study to do. You have 20 cases, just review what happened, report them, and that will be your case series. It's an observational study as being classified before. Let me see. And case report and case series, the important, it becomes first in literature. They are what you call it, the best available evidence. If they are the first comes. If they don't come for the first time, no, people have done some study. Most of the study we have now, all the syndromes you have now, it started as a case report, case series, and then people knows about it. I'll give you an example, Down syndrome. It was first described as one case. Then some people describe it as 5, 6 cases, Down syndrome. Oh, it was case report and case series. And then people did a lot of study on that matter. So case report and case series, it's important when it comes the first time. People just know what's going on. And after that, becoming more regular study like prospective study, retrospective study, comparison study, etc. Let us see this title here. See the title and you can understand the design. Continuing metformin through pregnancy in women with polycystic ovary syndrome appear to be safe to reduce first trimester spontaneous abortion. From the title gives you the hint that giving a treatment of a group of patients with a similar diagnosis. Look down to the design. It's a prospective pilot study. It's kind of pilot study, by the way, it's kind of case series because you are studying the same small group. Look, little bit, the line above that, how many women in that study? It's 19 women. So he tried an intervention here to the case series or case small group of patients for the first time. Do pilot study. Any study do it for the first time in a small group. They have another title called pilot study. So you're testing this in a pilot study, small group of patients. But the bottom line here, the link between the case series and this paper is the group of the patient within 20 patients. Diagnosis. The diagnosis is for all patients the same, and the treatment for all patients the same. They have no control group here. Are you with me? Hello?
Yes, we can.
You have to unmute them if you want verbal response, but they are with you. Don't worry.
Okay. Right. Another things you have to understand before you go to cohort study, you have to understand what's the difference between cohort study and cohort group. Cohort group that you assemble a group of patients have something in common. Okay, and that common things is depends on the study. If I'm doing a study in pediatric, I cannot mix adult. So I have to cohort all my patient is a pediatric. Suppose in pediatric I have two age group from 1 to 5 and 5 to 10. So you have to divide the age group to make it cohort. So you may cohorting the gender, you may cohorting the BMI, you may cohorting the baseline investigation, etc., etc., etc. So cohort group, it can be done as a cohort study or any study. Any study required cohorting of the group you're studying about. That's called cohort group. Look at the text now. A sampling group of people have something in common, depending on the study nature and the outcome. Okay? Men, I'll give an example now. Men who smoke are cohort with men who do not smoke with the same age study. I'm doing study like suppose I'm doing the study on lung cancer. I like to examine the patient who have smoked and who have not smoked. So you have to choose the patient with similar age, similar gender, similar exposure, either to direct to smoking or non-direct to smoking or in the same field. And then that's the cohort group. And then they do this. Again, I have to re-emphasize about the three different terminology we're using: participant, patient, and subject. When we're talking about patient, that means only disease. Talking about participant, including the patient diseased on normal control. Subject is the same use as a participant, by the way. Now, cohort study. Cohort study means it's kind of observational study. You like to link the relation between exposure and the disease over a period of time. The cohort study is mainly studying the exposure and the disease. In other way, meaning the risk factor and the disease development. That's the bottom line of this cohort study. You cannot do cohort study on procedure. No, it's an observational study, exposure and the disease. You can do cohort group, that's different story. So in the text, what they are writing in epidemiological book, it's observational study to observe the relation between exposure, meaning the risk factor, and the disease development. And that needs a time to develop over a period of time. Some other book, they give another definition. They said it's to determine the incidence of the disease and establish the link between the risk factor and health outcomes. If you know the meaning, whatever they're changing the text, it's the same bottom line. You don't have two now things: exposure, disease. Exposure means risk factor, disease, and then you need a time to see this outcome. Just remind you, the cohort study usually it is an observational study. You have observing what's happening without any intervention. This is an example. Cohort, there are two groups, either go prospective cohort or retrospective cohort. Look at the error in the top. I do prospective cohort. You can do it for 1 month, 2 months, depends on the outcome. I can do it for 10 years. Okay, so cohort can be small period of time and can be long period of time. If it's going to be a long period of time, it's called longitudinal study. So longitudinal study is a cohort of long period. Look at this now in this diagram. A group of a population, I choose a cohort group. So when I choose the group from this population, first things I choose cohort group. And then from the group, I do the cohort study now. I can divide them exposed and non-exposed. And then with the time, I observe the outcome. Sometimes the outcome acute. It comes within a few days, few months. Sometimes the outcome, no, it takes long time to develop. Most of the cancer, by the way, it takes long time to develop if you like to see how's this cancer develop. But if you have a cases of cancer already, you can do retrospective cohort. So retrospective cohorts, you have the diagnosis already, then you can go back on time and check it out. So prospective cohort is difficult to do because it takes long time, sometimes long time to do. Okay, but if your outcome is in in 3 to 4 months, oh, it's good. It's a good evidence study. So I can follow up patient 3, 4 months. I found my final destination of outcome. Cohort study can be done as prospective or retrospective study. Longitudinal study, it's an observational cohort, but that's the study taken long time to develop the outcome. Sometimes it takes 20 years, sometimes it takes 30 years. And the commonest and the famous study in literature called the Birmingham study, it took 30 years to finish, 30 years. They started by looking at the people risk factor to develop cardiac disease. So they follow up the patient BMI, they follow up the patient lipid profile, everything encountered the patient life. They followed up for 30 years. After 30 years, they came up with a conclusion that these are the risk factors to develop heart disease. So that's kind of difficult cohort to do as individual. It can be done as an institute. The other, it has very good evidence study, but it takes long time. That's called longitudinal cohort because the outcome here take long time to develop. You can choose an outcome take 1 year to develop. Still, you can call it longitudinal study, but your outcome is nearly arrived. Look at these titles now. These titles is reviewing the when you said longitudinal study, that means they are taking long period of observational to see what happened to these patients. The obesity, weight, and depression. Okay, look at the second title. It's straight. Longitudinal study, effect of divorce in children. They're gonna tell you in the detail of the study, this study takes a long time. They maybe take 3 to 4 years. So sometimes the title give you the hint of the design. The third title here, long-term health benefit, longitudinal study. So you can find it longitudinal study as a separate title, or you can find from the title itself tell you that it's a longitudinal study because the outcome take a long time to observe. This is the study. let me read it. Okay, yeah. This is a longitudinal study. They done for it's a retrospective cohort study. It's retrospective. Look at the design here. Retrospective longitudinal study of all women with surgical treated breast cancer. So the patient have breast cancer. They like to know what happened after the surgical treatment. Then they go retrospective. The bottom line here, they follow the patients who have the 2 years. Let me read it completely and then explain. They conducted a retrospective longitudinal study for all women with surgically treated breast cancer, okay, who were without evidence of recurrence. So they are choosing the patient, they are clear, they have no recurrence, and already have advanced, they have breast cancer. So they are looking for primary cancer afterward, okay? Within 2 years, they were followed up. So the retrospective done in 2 years, the last 2 years, and then they follow up for the patient for 5 years forward. So that's kind of, because he wants to follow up 5 years only and see what happened. Most of the oncology, they report their result in 5 years interval, like 5 years survival, 10 years survival, and so on. So this author chose to do longitudinal study, follow up the patient for 5 years. Those patients who have the surgery for the last 2 years, follow them forward in time to see what happened to them. Right. This is another terminology you might need to add to your design. Design does not mention randomization. Design does not mention blinding. Design doesn't mention these things. So this add to the design. So you may choose prospective study or randomized study, but you did not choose blinding. So blinding is not a design. Randomization is not a design. This is kind of add up security among to prevent bias. Why you do the blinding technique? Blinding, you do it to prevent observer bias. So when you record your observational, if I know this patient take this drug, so I might be having some bias. I want to influence my objective. But if I'm blinding, I don't know if this patient received treatment A or treatment B, then my observational bias is eliminated. So when you added blinding to the study, you're eliminating observational bias. Now, they divide blinding into single blind, double blind, triple blind. Sometimes they said open trial. When you said open trial, that means nobody is blinding. Open trial means nobody is blinding in the study. But single blind means that the patient doesn't know the nature of the treatment. I might be in the control arm, I might be in the active arm. So one arm doesn't know which is the patient. If I said double blind, that means the patient and the physician or the investigator doesn't know. Triple blind, if my third party, if I have my study including the histopathology. So the histopathologist, when I send him the sample, he doesn't know whether this sample is disease or this sample is a control. Or the lab, I send him the blood test, he doesn't know. So when you have the third party in the study, he's also blinding, that's called triple blind. So blind is an add up to the design, usually comes with prospective design, not with retrospective. Prospective design to prevent observational bias. Look at this design of the study. The title is Metformin Increase Ovulation Rate and Pregnancy Rate in a patient who received clomiphene citrate. My important here, look at the design here. He said randomized, double-blind, placebo-controlled trial. So, by the way, this is evidence number one. If you look about evidence-based medicine, this is evidence number one. Any randomized controlled trial is evidence number one grade. So it's the highest rank in the study. What's the meaning of randomization here? Randomization means everybody in the study have equal chance to be involved in either arm of treatment. So I do randomization like chance of you being in arm A or the chance of you being in arm B. This is a separate lecture, by the way, given randomization as a separate lecture, like because there are many ways of randomization. But for simple this lecture, randomization, you are randomizing your total group into 2 or 3 groups, depending on the computer random table or the random blocks. It depends on what type of randomization. But give you the high credit, give you the high rank, because you're eliminating every bias here. You're eliminating your, what you call it, selection bias. I don't select a good patient to this arm and don't select the bad patient to that arm. No, I want to eliminate selection bias. You put randomization in your study design. Double blind, we talked about double blind. What about placebo control? What do I mean placebo? Do I have to put it in every study? The answer, no. So placebo means that you put an intervention, have nothing to do with the study, and it's not harmless. If I'm doing the study like this study, I might put the placebo as a vitamin tablet. So one patient take the active treatment, the other patient take the fake treatment, which is in this study is vitamins. But suppose I'm doing the study on anemia. So my fake tablet here cannot be vitamin because it affects your outcome. So I might take the vitamin, I put sugar. So placebo definition, first it is safe, it doesn't change the result of your study. Okay, that's why people choose sometimes saline, sometimes vitamin, sometimes sugar. It depends on the study. If you study on anemia, I cannot put vitamin. If you study on diabetes, I cannot put sugar, put vitamin, and so on. So placebo can be done, but not in every study. And and make sure it doesn't harm the patient. And usually placebo doesn't put in the serious study. Like if I study in a cardiac patient, I put the patient have one treatment, the other patient on another treatment. In this study, because the outcome is serious, I cannot put placebo because this patient needs to be treated, whether with a new treatment or old treatment. So that's why placebo is not applicable for all the study. In the study who doesn't have serious outcome to the patient, you can. Okay? But if the serious outcome to the patient, forget about placebo. You can do randomized, fine. You could choose treatment. You can do double blind, fine. But don't add placebo in a serious outcome study. Randomized study can be done, by the way, in single center or multi-center. Of course, the multi-center have the reason to do multi-center because you want to increase the sample size. That's one of the things. You want to increase the sample size, you choose multi-center. If you have enough sample size, you have good referral center, then you don't need the multi-center. So usually multi-center, bottom line, you want to increase the sample size. Of course, when you increase the sample size, the conclusion will be more valuable than you do small samples. Again, you can see this multi-center randomized control. So randomized control. Right. Let us now talk about something. We talk case control study. Case control study, that means get the diagnosis first. Now the diagnosis first is lung cancer. If I go back on time, I like to know the risk factor. So usually this kind of study, to know the causes or to know the association of cancer, you have to do retrospective because it takes a long time to develop and you don't have time to wait for 10, 15, 20 years to see what happens. So do retrospective study and follow up the patient by history or by file findings, what happened, what they are exposed to. So here you can do case control case mean, the diagnosis, go back on time and find out what happened. Here it's overlap bit with cohort retrospective, but sometimes in the cohort retrospective, you don't know the final diagnosis. I know these patients or this group of patients, they have some cancer, whether lung cancer, blood cancer, or any cancer. I don't know what they are exposed to. But if I know the specific disease, like I'm talking about lung cancer, now, no, the terminology changed. I have to do case control retrospective. So the case now is the diagnosis. The control, I can see the similar group of patients, cohort group of patients, have not exposed to these things. Okay, so when you go to back on time, that means I like to know the risk factor. People call it associated factor. People call it predictor factor. There are many names under this. So that kind of retrospective case control. But suppose I like to see what happened after the diagnosis, like prognosis. Now, from the diagnosis onward, I can do prognostic study. Now I can do cohort study. Okay, cohort prospective study, because I don't know what happened. I like to know what happened. So I follow up of this patient over time. So when you follow up patient over time, you like to know what happened. That means prognostic study. Prognostic study, you have to look at prognostic factors, because the age can tell me how long the patient might survive. The severity of the disease. If the disease is very severe, stage 4 cancer, I know the prognosis is poor. So many things can control your prognostic study. Age, severity, availability of treatment or effective of treatment, the intervention, general condition of the patient, associated disease. If the patient have multiple medical problems, I know that the prognosis is going to be poor, and then associated with comorbidity. So retrospective study is a good study in this kind of disease to know the risk factor. If you want to know what happened, is go for cohort arm, or what we call it prognostic arm. Case control, this is the two common things you're going to see: case control study and cohort study. Case control have another name, either they call it historical study, historical or retrospective study. In case control, look at this, case and control. You should have two arms here. If you have only one arm, it's case series. You have no control. I'm describing what happened to this patient. Do you have a control? No. So it's a case series. If you have a control, it's case control. It has another name called historical, retrospective, or retrospective case control. Usually you look at the causation of the outcome, mean the risk factor for the outcome developed. This is easy study to do. It's quick and cheap. If you do the similar thing, prospective, let us see now, I have lung cancer, I like to know what happened to them. I like to know prospectively what happened to them. That's called now cohort study. The outcome, it takes longer time to see. But this is good evidence because you have no bias. You're bit eliminating some bias here. So cohort study and case control retrospective, this is the difference issue between them. One look at risk factors, the other one look at prognostic factors, and then choose what design you like to select. That's up in the result section. When you do design of case control study, look at risk factor, and I have many risk factors to see. I have to see smoking, duration, exposure, tobacco, age, gender, etc. When you look at the report, you can say lung cancer associate. Look at it. I'm not saying cause. The report association. Association means one of them of smoking. If I said how much that smoker to develop lung cancer, I put 2. Odd ratio of 2 mean double the risk. Odd ratio of 2 is doubling the risk. 2.1, that means twice as control patient if you smoke to develop lung cancer. So the design have something to do with the how you interpret the result and how you do with the statistical analysis. So in that design, when you have multiple risk factors, you have to do what you call it regression analysis. Regression analysis, as you can see here, rank to you all this risk factor, how much increase the risk of lung cancer. Smoking per se, it's double the risk. But that smoking, if you go in detail, the more cigarette you smoke, the more risk, 2.3. The more duration you smoke, it's triple the risk, 3.5, and so on. So some of them, they are higher risk factors. Some of them, they are medium. Some of them have no risk. Like the last one is gender here. Gender doesn't increase the risk if you smoke for that long period of time. Both gender can develop the outcome. Look at this title now. Even the title gives you the hint. Risk factor for primary lung cancer among non-smoker women in time. That meaning you like to see non-smoker and smoker, okay, to see who developed the lung cancer. We know that non-smoker develop, but you know that lung cancer can develop in non-smoker. Why the non-smoker? He like to dig to see why the non-smoker develop. Either is it inheritance, is they have something exposure, and so on. Look at this, another study. He give you the design upfront. Type of wine and risk of lung cancer, a case control study. Do you think this is prospective or retrospective study? It is retrospective because he liked to see type of wine they are cooking with wine. He said in the paper, the fumes of this wine cooking kitchen in the woman can develop lung cancer. So not the wine drinking, it's the wine exposure to, because they're using in the cooking. Okay. Look at the third paper here. He said non-small lung cancer, risk factor, and treatment survivorship. So he is in this paper, it's a very strong paper, because you look at backward in time risk factor, and you look forward on time to see the prognostic factor. You look at both. You remember the diagram, backward and forward? He did both in one paper. So look at the risk factor and follow up the patient further for 2 to 3 years to see what happened with this disease. So from the title, you can predict what design might be, and then you go read the paper. This is another design under observational study, and this is commonly do. Most of you guys, residents, fellows, comes to my office, they're doing kind of cross-sectional study. What cross-sectional study? It is a single time study. Let's make it easy, and most people like it. You measure at a single occasion of various disease, injuries, and health outcome knowledge about at a point in time. What's that mean? You're doing a survey, kind of cross-sectional survey. I want to see the incidence or the prevalence of certain diabetes among obese patients. So I have chosen 300 patients or 300 participants, take their weight and take their blood sugar level at one time. No follow-up. Then I can say, oh, 5% in this cross-section. I might use it to know the knowledge. Some of you guys said, oh, I like to see the people knows about COVID, coronavirus. So they sent questionnaire to examine the knowledge of the patients, to examine the knowledge of physician. So this is kind of questionnaire examining the knowledge, or questionnaire examining the psychological impact, or examining the disease presence or absence. So cross-sectional study is usually single point in time, whether you do survey or you do questionnaire. It's the same thing. Survey means I examine. I might do some testing. Questionnaire, no examination. Okay. So at this point in time, I can see the risk factor at one point in time. I said, okay, 5% of obese diabetic. Is that reflect the actual? No, it reflects only the cross-section you're examining. I'm examining the King Abdulaziz hospital staff only. It does not reflect the general population, but it reflects the hospital population. So people like it because you're examining 1.1 item at a time, and it's quick to do, and it's easy. It provides information about what happened in the current population. But I might do multiple cross-section study. I do in Riyadh, I do in Jeddah, I do in Dammam, and add up this result. It will be more powerful study. So cross-section study per se, it's kind of descriptive study and analytic, by the way. You can do some analysis out of this description. You do it at one point in time, whether you do it as a survey, so you're examining all patients, you take a weight, you take some blood test, or it's purely questionnaire. I send the questionnaire examining knowledge, examining psychological impact, examining the opinion about what you expect, what you think. So that's called cross-section study. It's two types, descriptive and analytic. It's quick and cheap. It can be compared at two populations. I can compare Riyadh versus Jeddah. I can compare King Abdulaziz versus King Khalid Hospital at one point. You have no lost follow-up because you have no follow-up. That's why people like it. Just finish the questionnaire, analyze it, and present the results. But this kind of study does not give you the risk, the causal relationship, not like a cohort study. So there is a limitation. Although it is easy, it can answer some questions, but don't link it to find association or causal relationship. Maybe this kind of an example in ENT. The vocal cord paresis, medical specialist opinion. Look at this. The title tells you medical specialist opinion. So he liked to send a questionnaire to ask the opinion on standard diagnostic and laryngeal findings. So he asked all his colleagues about his opinion about standard diagnostic testing. Look at this cross-sectional survey using questionnaire. So the design is clear. Tell you, I want to do cross-section survey, examining questionnaire to see the specialist opinion. So it's fulfilled all the criteria of cross-sectional study. What is ecological study? Ecological study, that's more wider than cross-sectional study. It's evaluate association between exposure and disease using a population in each geographical level. That means it's a large multi-region study, exposure and disease kind of cohort study now. When you said association, that mean risk factor. Usually association mean bad things in medical terminology, in research terminology. When you see association, you look at risk factor. It's not a correlation, it's not a relation. Correlation, two different things, whether increase or decrease. Association, risk factor, and disease. So that's why association between exposure mean risk factor and disease in a population at geographical level, not one region. When you do ecological study, I have to do multi-region and compare the results. This kind of called ecological study. It's used to measure prevalence, incidence of the disease in different regions. Look at this now. I'm measuring diabetes in region 1, region 2, region 3, up to 6. So when I'm reporting the result, 5-6 regions now, I'm doing like obesity related to diabetes in multi-regions now, 6 regions. It's kind of ecological study. Okay, when you report it in multiple regions, rather one region, it's now kind of ecological study. I can do it at multiple countries. I can report my results in global. It's kind of global. Another name we call it ecological study. I reported my results among the people, among the other world studies. This kind of people sometimes draw it in the map. You see it every day. You can see the state map. You see where is the corona. They can say here is high level of corona, and this is rare, and this is no corona, etc. This kind of mapping, doing multi-regional study and present the data, is kind of called ecological study. So he presenting now the prevalence and the incidence of the disease. The disease now is corona among the whole state. So I can say in the state A, it is 20%, the state B is 50%, state A, state C, it is 10%, and so on. This kind of reporting or this kind of study is called ecological study. Now, there is a design called crossover study. Crossover study. Why I use crossover study? And if you look at the design list, we didn't find crossover. But why you do crossover study? One of the reasons I do crossover, you know that prospective study, it's going to take a long time to develop, especially if you have a large sample size. I have 100 patients. If I want to start now, I might take 1 year to finish this. So in that case, if I have 50 patients and do the intervention twice, I do design now called crossover design. So it is randomized prospective. This is not going to change. But because of the sample size, I cannot do it with the tool I'm having. I have to do crossover. Mean I used my sample, my small group of patients twice. So still called double-blind, randomized crossover study. That means I take the patient intervention A, okay, the control intervention B, and after a period of time, I switch the intervention A to go to B and B to A. So if I have 20 patients, I'm using it twice. That means I end up having 40 patients. So the reason to do crossover study is to double the sample size in a short period of time. So you are shortening the time because of the sample size is doubled. So it is, by definition, it is parallel group exposure to one allocate intervention, and then you switch the intervention to the other. Of course, there is some rules. After switching, before switching, you have to have what's called washout period to eliminate the effect of the intervention before. So you have to say the switch time, take 4 weeks, clearance period, and then I start my second intervention. So when you do the crossover study, you have to do it the first time, do it as it is. When you do the follow-up, when you're switching over, you have to do what you call it the wash-up period, which is maybe 2 to 3 to 4 weeks, and then you start again with the similar study. Here, another example. It is randomizedly allocated. Look at the up, it's intervention. The down is control group. Now I observe the results, control, observe the result, and then I switch. Look at the green color. The green color goes down and the red color goes up, and then follow up. But in between, there is a washout period. So it is not kind of primary design, it's kind of implementation of that design. I want to do randomized study, it's gonna take long time. I want shorting, so do crossover study. Double your sample size in a short period of time. Okay? And then observe the result. So when I observe the result, look at this control result and this control result I observe, and this intervention result. Look at this title now. With more terminology, you know, the more secret of the title can be read or can be understood. Phase 2, randomized, double-blind, crossover study of hypertension and placebo. In a participant, look at this. Why he used participant? Because he have one arm of the patient is not hypertensive. Or he might have small group is not hypertensive control. Okay, in a patient with high blood pressure. So sometimes put participant, sometimes we put the patient. If I put patient, that means all of this study group in yours is a patient. If you put participant, may have some, or should have some non-patients. But the bottom line here, look at this randomization. That means it's evidence 1, double blind. He used crossover here. The secret he used crossover in this study because he wants to double the sample size. You have a problem with the sample size. So you allow, one of the things you allow in your study to do crossover for this kind of tackling the problem. Look at the second title here, Bacterial Supplementation and Irritable Bowel Syndrome, a randomized, double-blind, placebo control, similar. The design here, it is similar. But you have to understand everything in the design because you have to execute it. So my next talk is going to be how you execute these words. It's not just put a fantastic word in the front, and when you implement it in the study, it's not applicable. So you have to choose the right terminology, and then how you apply each one of them. Randomization, you have to choose double blind, that means real double blind, placebo, etc. This last study here, crossover study, he doesn't say double blind, he doesn't say, he just said straightforward crossover study. Okay, so crossover can come with straightforward study, or it can come with randomized, double blind study. Description, this is a randomized, double-blind control crossover study, dose escalation study with chronic cough. Okay. But look at this, one of the implementation things. This study will take 21-day treatment, separate by 14 days washout. And then there will be 14 days follow-up period. So he will give you not just the title, he tells you how he implemented it. The treatment arm, the first phase before he cross over is 21 days, and then give 2 weeks, no intervention at all. They call it washout period, and then he start the study. Okay, so this kind of crossover rules comes on the way. Right, the last group, experimental study, we said people call it clinical trials. Experimental doesn't mean you're experimenting in human. No, that means the study done safely in animal, and you think that is ready to go in human phase. It is first time you apply this treatment in human. Okay, and that's called clinical trials. When you go to the clinical trials, there are 3 phases before the medication comes to the market. That's why you have a problem now with Corona. Everybody have found a medication. Yes, does it work? Nobody knows. They want to try it. They cannot try it in the first group of patients and said, oh, it is working. No, we have to do it in 3 phases. First phase, you adjust the dose. Second phase, you put a small control, bit of randomization, and the third phase, you have to do full randomization and follow up for at least 1 year. That's why the treatment for corona now, it is maybe in phase 1, phase 2, but not in the final. That's why the people said we don't have a treatment available yet, because it takes time. Yeah, that's the therapeutic. When we talk about clinical trial or experimental study, we talk about either therapeutic phase, which is medication, surgery, procedure, machine, or radiotherapy. Or talk about preventive phase, which is vaccine. We will now talking about clinical trial, vaccine, and in the same time look at the clinical trial and therapeutic. Both of them, they already manufactured, but they need to be tested. It takes long time to see the effect. It might, that's why people said, oh, vaccine and treatment. Final result might take years to see the result. So that's all under what you call it experimental. People call it clinical trial. Clinical trial, they have many subdivisions inside. Whether therapeutic arm, looking about medication, procedure, surgery, developing a machine like laser machine, or radiotherapy to treat something. Or you talk about preventive measure like a vaccination or vitamin use to prevent like neural tube defect, vitamin use in pregnancy to prevent iron deficiency anemia. So this is called preventive part. Or behavioral. If the people do this behavior, they may prevent from development of that disease. So preventive measure either vitamin use, vaccine use, or behavioral intervention. That's all under experimental studies. How much time we have now? Let us see. No, this is important. We can't skip it. When we talk about control study or uncontrolled study, uncontrolled, we said study not controlled. It's kind of case series, but it has a purpose. I do this uncontrolled study for a certain purpose. I want to see the efficacy of treatment. Suppose I introduce the vaccine or introduce a medication now to treat corona. I want to test it in a small group of corona's patients. So the disease patient affected with corona, I give them the intervention and observe what happened. If the result is encouraging, good outcome, then I can go to the second phase, which is the control study. So uncontrolled study is wanted in efficacy phase in a pilot study, small group of patients tested for the first time.
دكتور أحمد.
نعم.
allow me to interrupt you. صوتك شوية يبعد، بدأ يصير بعيد.
يمكن هو على فكرة الزوم له تايم لما الظاهر لهم 60 minutes يضعف بعدين. الحين ضبط؟
لا ايوه ضبط الصوت. اور اكونت لا احنا بيد اكونت، فخذ راحتك. عندك تقريبا يعني 40 يمكن 50 minutes باقي لك تقريبا.
طيب انا حخلص هذه حاعطيكم 5 minutes بريك هنبدا اللي بعدها.
طيب تمام اوكي.
الانكنترولد ستدي احنا قلنا فيها efficacy مطلوبه. It's wanted because you're testing efficacy and you do it in a pilot group, small group of patients, to see the effect of this intervention, whether it is work or not work. And then if it's successful, I have to do in a control arm. In a control study, there are 3 types of control. Either do it, let me see the diagram here, yeah. Either do it in concurrent control, mean parallel. I have 2 arms in the same time, I follow up the patient. That's called parallel or concurrent control. Sometimes I do sequential control. Sequential control means I do the intervention now and see the outcome after. So the patient have, like I do look at the chemistry before sleep surgery. I see the chemistry before and they see the chemistry after intervention. That's called sequential. So there's the same group of patients. I check them twice before intervention and after intervention. That's called sequential control. Sequential control, that means the group tested twice before and after intervention. Concurrent control means the two groups have the intervention or no intervention parallel to each other in the same period of time. Sequential, no, different period of time. Then sometimes I have external control. So I do my result here. I compare my result with something in the past. So this antibiotic improve the condition of the patient. Old antibiotic being used before give 5% improvement. So now the control, not concurrent, not sequential, but it's called historical control. You take in your result, compare your result with something in the past. Okay, so control arm have three. Either you do concurrent, like in this diagram, control and intervention. Okay, this is called concurrent control. Or you do sequential. Before intervention, what happened to the people? After intervention, what happened to the people? Okay, that's called sequential control. And that's what they do now. They said, this is drug to treat corona. They are very sick patients. After giving them the treatment, they are improved. Same patient. But this is not a control arm. This is same group of patients before intervention and after. When this is showing some good results, you can do a controlled study. So people now, they have successfully developed many treatments. But in this context, patient improved. Patient admission instead of 11 days in ICU, now 7 days in ICU. Is this applicable for all patients? We don't know. So we have to do a control study. Get all patients, put something with this intervention, something without this intervention, to see is your intervention help in improving or not help. Or maybe the patient improved by itself. You don't need intervention at all. Just natural immunity make the patient recover. So that's why you need to do a parallel study. Sometimes do sequential for initial, and then you can generalize it for parallel study. Look at these titles now. It summarizes all what we said in one line. Randomized control trial. Randomized control trial, evidence number 1. Control trial here, parallel arm. Trial means in human. When you word control trial, that means the study done in human. So randomization, one of the elimination of selection bias. Control, you are comparing intervention, no intervention, trial done in human. Multi-center, yes, you are much more stronger than single center. The reason is because of the sample size. Okay, randomized placebo control, as evidence is the same. 1, 2, 3, evidence is the same. Number 1, for all of them. The first 3 titles, they are same evidence. Number 1, but each one have different tackle. One taken multiple center, the other tackle single center, the third added placebo. Okay, so placebo is not going to add in the evidence, but it eliminates observational bias. Retrospective study, that's classical retrospective study. You are reviewing the chart for something happened in the past. I'm reviewing the patient who have this procedure, what complication they have, what improvement they have, what their outcome, all of this. This is called retrospective. Prospective, now you are doing cohort prospective. Usually, cohort prospective, usually, but we know now, when you go deep in cohort, by the way, there are 4 types. 4 types. But the 2 common types is prospective and cohort retrospective. Case control study, we know now, it's kind of finding the disease first, look back on time, look at the risk factor, why this patient developed the disease. Crossover is different from cross-section. Cross-section study, you take a group of participants, you send them a questionnaire, or you survey them, you examine them. Either you take the weight, you take the blood to see the diabetes, to see the cholesterol, to see this kind of cross-section. Case report, I think you're familiar with. case series you're familiar with. This all of kind mixed design summarize all what we have said. So you choose the design before to match your idea, and then you follow up the consequences of that design. I cannot do retrospective study and expect to see something in future. No, retrospective review, and I know now retrospective study is what you call it level 3 evidence. Level 1 evidence randomized control, level 2 prospective non-randomized, level 3 evidence is retrospective. So it's number 3, it's a weak evidence, but maybe this is all what you have. But if you want the strongest evidence, number 1, you go for randomized. Okay? I think I finished the study, the first lecture. We'll give you 5 minutes. I'll cut down and then rejoin again.
يعطيك العافية دكتور.
إذا في سؤال.
ايوه طبعا احنا قبل ما ناخذ البريك لو ناخذ what do you think should we take some group of questions? I have some questions.
Go ahead. اسألها.
خلينا نشوف الشات. Anyone has question please put it in the chat or feel free to raise your hand and I'll unmute you to speak. طبعا انا حبدا بس على في اول سلايد انت you mentioned the qualitative research. Can you give us an example of qualitative research, something in medicine or related to ophthalmology that we can apply?
والله you can. يعني some of them they take an OR timing. How you cut down the OR time, switch over time. This is a quality improvement. So I like to do the OR time instead of patient switching. Patient take 1 hour. Because they are checking the patient name, the patient eye, they checking this one. Maybe we find something to cut down this time, improving the quality of service provided. Okay, it's a big chapter. In qualitative, usually it is improving the service outcome.
معلش I've lost you. ما أدري my account went out and in again. معلش did you mind to repeat what you've said?
طيب. Quantitative research. Sorry, qualitative research. You're improving the quality. Yes. Quantitative, this is something we're measuring the outcome by numbers. But qualitative research, you like to improve the quality of service, quality of things you provided. One of the examples we usually do, in your specialty might do improve the quality of turnover patient in the OR. Why the patient take 1 hour to switch from case to case. So I like to go improve that time. Maybe that time can be shortened to half an hour. How? By making things written, by making things upfront, by making the double check quickly, and so on. So anything you improve the quality of the service provided, it is under qualitative research.
If I want to put a research question for this research, for example, improving the turnover time or
maybe education. I want to improve the knowledge. I want to improve the nurses' knowledge. How do I improve the nurses' knowledge? Maybe I need to give them handouts. Maybe I'm giving them lectures. Maybe I give them courses. This is improve the nurses or the doctors qualitatively. So improve their performance by increasing their knowledge. So anything you improve the quality, that's called qualitative research.
ايوه وطب احيانا research based questionnaires they include it in qualitative research. Is this correct or not?
Yes. الكوشنير معظمها to improve it's qualitative. معظمها
qualitative. طيب في احد does anyone have a question في الشات وفي البارتيسيبنت or I can go to the next one. ما في احد.
دكتور ابو سيف بس الله يعطيك العافيه دكتور احمد بس keep in mind انه دكتوره دانيا الليكتشر تبدا 3 اوكي.
طيب عشان حاطيهم 5 minutes to switch to the second lecture.
طيب اوكي ترى في سؤال هنا قبل ما switch to the other lecture من وليد السرحاني. Are review articles considered to be qualitative?
Yes. الارتكل فيها
Review articles. Under what category would you put it? هل quality?
لا, it depends on what you are reviewing.
Yeah.
Are you reviewing something numerical, like something surgical, something medical? That's no. Are you reviewing something procedure, like to improve quality? That's something. I mean, reviewing article depends on what you are reviewing.
Yeah. Does this answer your question, Ya Walid?
Sometimes you have both, by the way. You have qualitative and quantitative. I heard your study last year, ophthalmology. They are comparing the histopathology with the radiology, with the clinical findings.
Yeah, correct.
Yeah, that's kind of both quantitative. So you are seeing the numbers of which one will give you the higher diagnostic tools. Is the histopathology match with radiology, match with the operative findings? And then I found that the radiology is way behind, giving me some clues. In my study, I found that radiology misleading me, give me the false impression, and then interoperative give me an impression, and the histopathology give me impression. So maybe in this three link, I found the radiology is the one drop out, is the one below the standard. So I want to improve the radiology quality. Maybe the radiology, instead of doing regular scan, maybe doing the MRI, maybe doing something. So in my message, it can be both qualitative and quantitative at the same time. I found the link between the three. I found where is the problem is, and then I changed that attitude. Instead of doing this routine X-ray, no, I need now to do improve that quality. I need to do MRI for all patients with this presentation. So now the arm of radiology, it's in harmony with interoperative finding, and the histopathology is not surprising. So either I do qualitative, pure qualitative study, or I can do both.
جميل دكتور أحمد، كلير. تحب نبدأ عشان الوقت ولا تبغوا
I think you can go ahead بعد الدسكشن هذه لأنه
طيب خليني بس اخذ small break and then we start. انا حضطر اني اقطع الخط عشان بس لان الوقت هو
that's fine.
الوقت مسموح، لان الزوم اللي قبل كده بعد 60 دقيقه الظاهر يقطع.
لا
ours will not بس انت you can stop sharing the screen now you can stop your video until you fix your presentation and
لا هي جاهزه لا البرزنتيشن
yeah no problem.
لا البرزنتيشن جاهزه. فين شير سكرين فين راحت شير سكرين؟ لا فيها البرزنتيشن الثانيه.
ايوه بس share the screen with the second presentation.
هذه هي
methods.
هي materials and method اللي هي implementation of study design. بس خلينا ناخذ طيب 2-minute break and then I can.
sure. No, feel free. انت you can leave.
لو الواحد فاطر كان اخذ له كاسه قهوه ومش للاسف يعني حنضطر كده نريح الصوت شويه وبعدين نبدا.
حطيت كرسي جنبك الله يعطيك العافيه، بس اهم شيء تخلص قبل ما الدكتوره دانيا تبدا علينا. طيب اوكي. So the group مين اللي هيبدأ study بعد هذه المحاضرة؟ You should choose one of the categories of the designs that he mentioned and start working on something.
Doctor, I have a question since we are waiting for Dr. Ahmed. Case control studies are called for the يعني we start with an outcome and we look for an exposure مثلا lung cancer and then we look back at the files for smoking.
Sorry أنا I have to.
تفضلي.
لا أنا بس عشان.
Take it.
عندي مكالمة ف just a second. خليني بس حتى أنا عندي ترى I don't know طلع لي كأنه it stopped by the way.
طيب back to the second session معايا.
اتفضل دكتور احمد.
تفضل يا دكتور احمد تفضل.
السكند سيشن هي material methods. Most of you when you read material method it's a boring section in reading. When you read, most of you guys you skip it, start with abstract, read introduction and then go to the conclusion and results. Material methods important for you to read, to know how you do the study. It's the key how the study is done. It's a boring session for the reader, but it's an important section for the people who like to do the same. Now look at this. Objective in the paper components. Introduction, objective. Here material method come immediately after design. Why it's immediately after design? Because it's implementation of the design. How you apply this design. So you have to tell me how this design is applicable. When you said I did randomization, you have to give me detail how you do randomization. Blinding, how you do blinding, and so on. So everything you want to do in the study, you have to explain it in detail in material method. That's why it's boring for the reader, but it's important for the writer. When we look at in general, most of you guys taking courses, at the end, I need to do paper. Okay? When you have a research question, you cannot do the paper from research question, from design, and etc. No, you have to go literature review. Literature review means not just the title. You take in the title related to your research question. Read those articles. People said each paper you have to read 20 articles to summarize and to give you the input to your paper. Most of you, they don't. They just read one paper. Oh, I have enough information. I can do. You cannot do. You have to read a lot to produce that paper. Even if your research question is unique, you have to find some link in literature. So the key issue, go to the literature review. Read as much as possible in that field, summarize it, and criticize. See why this paper is weak, why this paper is strong, why this paper did not discuss, and so on. So criticizing means see the weakness of each paper. And then now you finalize your research question plan. So my research question was in certain area. After reading the literature, I found a lot of people did this way. I might find people doesn't do that way. So my research question now be modified to be done this way. So your research question initially, it might be changed after reading the literature and find some fine tune there. Then study plan comes, put your clear objective, put the design, match that objective, and now how we implement this design is the material and method. When you writing your paper, you write introduction first, okay? An introduction is a summarize of literature. So introduction of that art of your paper is summary of literature review, okay? And find what's the problem in literature and why I chose this objective. So my objective, because there's no much randomized study, or there is no much cases reported, or no much this procedure is being reported, and so on, or no much follow-up time. Maybe your follow-up time 2 years follow-up, and most of the paper in the literature 1 year follow-up. So people like to know long-term follow-up of that objective. So an introduction usually is summarizing what you have done in literature review. And this is up sites where you do literature review. People, they do Google review. No, Google is not medical. Google will not give you medical input. Google will give you a general input. But if you like to go to the medical input, go to this medical website, PubMed, Medscape, eMedicine, on all of this. These are the scientific medical websites. Google will not help you. And then we go from there. Let me cut down this because it's going to take longer, so I need to go direct to material method. Okay? And material method now, I want to implement the study. So what is the study design? Study design is prospective design or retrospective design. That's the two common design, or cross-sectional design. All of them, they should have ethical approval. You should mention clearly the study is approved by ethical and put the ethical approval number. And keep the certificate, because some journal, when you submit your publication manuscript, they ask you where is the IUB certificate. So in the text, you write I have approved, and this is my approval number. If they ask about certificate, attach it. If you don't ask, keep it on your record. Then you have to mention where is the study conducted. Is the study conducted in the hospital, outpatient, in multi-center, single center, etc.? That's important. Most of you guys, you said it's done in King Abdulaziz Hospital. Doesn't mean anything. It's done in inpatient or outpatient, because two different follow-up time. Inpatient means you have to follow up during admission and so on. And you have to mention the center. Are you doing in one center or two center? One department or two departments? Maybe the ophthalmology department with pathology department, ophthalmology department with anesthesia. So this should be clearly mentioned in your material. Okay. So first, the departments, inpatient, outpatient, how many departments in the study, and how many centers in the study, single center, multi-center, etc. Now people confuse about study time and follow-up time. Study time means I collected patient between 2013 to 2015. Do I include 2016? Sometime, yes, because the patient recruited last month in 2015 as a recruitment and needed 6-month follow-up. So he got to the 2016. So be careful about follow-up time and study starting time and end time. Study time, that means recruitment time. So when you put recruitment time in your study, don't put the next year follow-up. So people understand that, because you mentioned in your study, each patient has 6-month follow-up. So the patient at the end of 2015, of course, the 6 months go to 2016. So don't change your title to 2016. No, stick to 2015. That's your starting time of the study and end time of study. That means the recruitment. Follow-up time is different. Even if you go 2016 or 17, doesn't matter. Then you have to define your outcome. So my outcome here is recovery. And have to define what you mean by recovery. Recovery for how long? Or cure, or treatment, or improvement. You have to define what you mean by cure. Cure means at least 2 years the patient is in good condition. After 2 years, different story, maybe. Then you have to say the standard method of measurement. Are you measuring your outcome by what? Are you measuring by subjective method or objective method? Subjective method, like ask the patient pain threshold. So you give him the pain scale and give him pain scale 1 to 10. Or I measure the blood pressure after the procedure. That's objective. And that first one is subjective, and so on. So standard method of measuring in your study the outcome. All of this, by the way, is applicable to design. You cannot execute design by name. These have steps in going through implementation of your design. And then don't forget to mention inclusion and exclusion criteria. Don't say included everybody with cataract. No. Maybe you're including diabetic cataract, maybe you're including hypertensive cataract, maybe including a normal cataract. So you have to mention inclusion and exclusion criteria. How many patients you need in this study? If the study is prospective, some study they need, yes, they need informed consent. That's mandatory for the study. If the study is intervention study, you need to do some intervention, you need informed consent. Sometimes they ask even questionnaire study, they said, okay, I can take verbal consent to agree to participate in my study. But informed consent is mandatory written consent in intervention study. So please be aware of that. Now, you go to the direct to the first lecture, randomization, and how you form control group. Now, before randomize, you have to know the sample size. I cannot say I'm choosing 50 patients. No. How you can choose 50 patients, not 100? So the one tell you how much number you need in the study is called sample size. So the sample size is a preset number for prospective study. But suppose I like to do retrospective. So retrospective study doesn't need sample size because I'm reviewing all the chart I'm having. I have 50 patients, I review 50 patients. I have 100, I review 100. So it's not planned number, it's the number already done. So randomization only needed in a prospective study. It's accompanied with sample size. So I get sample size first, and then randomize that sample size to make 2 comparable groups or 3 comparable groups. Okay? Then the total number of study population, that's from the sample size, can be determined. Or retrospective, I can tell after I finish, I have total number of my patient is 80 patients or 70 patients. And then from that number, I can make group and subgroups. So total number can be divided in group 1, group 2, and group 1 divided in age between this and this, or gender this and this. Okay? In each design, by the way, it has different statistical method than others. For prospective study prognostic, you need this kind of statistical analysis. Of course, there is some statistical analysis common, like student t-test and chi-square test, but there is some analysis needed for risk study, like regression analysis. Something needed for treatment outcome, like life table analysis, what you call it, Kaplan-Meier analysis, and so on. So that's part, a statistician will help you. So you don't need to know detail of this one. So when somebody asks me about analysis, I tell him what's the design. They think that the statistician doesn't understand the design. No, they study this. If you give me any analysis or even sample size for design, I can tell you because of the disease prevalence, I can calculate sample size. When you give me analysis, tell me this analysis for prospective study, for randomized study, then I can choose the special statistical method matching your design. So that's one you don't need to know, but you have to tell the statistician or send him the copy of your manuscript so he will tell you what to do. Data collection sheet, that's you have to sit it before, once you make the design, make the grouping. So you have to make the plan, what data I'm gonna collect. If you don't have this plan, data collection sheet, you finish your study, oh, you are missing a lot of information, important information. So I go back, it's too late. It's too late to go back. So please sit down with your senior, make the possible data needed to collect to contribute to your study design and to contribute to your final objective. So data collection sheet should be planned front end. This is a questionnaire study. They make this data collection, or they make this information in the questionnaire. They make every possible question might be there related to urine incontinence. Then with the statistician, this can be transferred to the numbers later on. So you make the data collection sheet in text, the possible like height, weight, number, nationality, all educational level, occupation, and then you make 3-4 pages, doesn't matter. Suppose your study is asking every bit question, fine. Then you sit with statistician, how this text be transferred to the number later on for analysis. Because we cannot analyze text, we analyze numbers. Then we can make an Excel sheet out of this one. And from Excel sheet, we give you a code number. And then after you finish your text, we can transfer it in Excel sheet, and then we can make statistical analysis. A study population, you choose it. Is it a hospital base? Is it an outpatient? Is it open, like general population? So we have to mention what type of study population you are selecting. I'm doing this study examining all post-operative patients. So now my selected post-operative patient, when they go home, I like to follow them for 6 weeks. All of this important information you have to mention in material method, not just the design, you put it and think that the people understand. No, the people like to see how we implement this design. Are you studying the patient in and out? Are you studying to hospital? Are you studying and so on? So you have to be clearly defined your study population, location, numbers, classification, and position. Here, the similar slide as before, the concurrent, or what you call it, parallel control. I think we mentioned this in the previous one, the difference between cohort group and cohort study. This is an example. Let me see how much you understand. The characteristic of the group, or what you call it, demographic data, it's common in most of the study. Like, I like to know the age, height, weight, BMI, ethnic background. If the smoking related to the study, I put it. If alcohol related to the study, I put it. So you can remove and put these factors accordingly. Physical activity, does it relate to your study? No, so you don't need to put it. But if it related to study, yes. Level of education, I can, yes, and so on. Family history, that. Those are the common, what you call it, characteristic or demographic data. Okay. So what about confounding factors? What's the meaning of confounding factor? Confounding factors is the factor you did not put, and it affects your result. Suppose in this study, I did not put like BMI. I think initially it's nothing to do with the study, but people think that outcome might be related to high BMI or low BMI. If you miss to put BMI in your study or comment on BMI, that means you have confounding factor. So confounding factor is the factor missed in the study and affect your outcome. So when you put your outcome or the things you are looking for in the study, make possible that you test, you try everything possible. Anything missing, we said it is confounding factor. So don't try to miss any possible relative information related to your study. This is demographic data of study about pre-operative information about medical comorbidities. He put all these possible characteristics: age, BMI, ethnic background, gestational week, because the study done in pregnancy, gravity, period, and so on and so on. Usually table one give you the demographic data or characteristic of your patient. That's what we call it now, cohorting the groups. So the group, they are matched for these things. Though this study is not a cohort study, but this is a cohort group now. Group one have this intervention. By the way, this is two kind of surgical sutures, Dixon's versus bicrelateral. This kind of two surgical suture comparison. But this suture, they like to see the healing, wound healing, and the wound infection rate. So they have to match the group based on these factors. Okay, and then table 2, table 3, they show up the result. But cohort the group first, and then you see the result. What's this? This kind of questionnaire. Yeah, this kind of questionnaire. Low risk lifestyle. You look about the lifestyle, they develop some kind of questionnaire, and they put all these 4 or 5 risk factors. Right. In your study, you have to start. What is your starting time of your study? Not the starting period now, starting time. When is the patient gonna included in your study? Included in the study, that means after the diagnosis. So I included all conjunctival patients. That means already the diagnosis of conjunctiva included. And then I start either treat or observe. So starting time, or what you call it, 0 time, all patients included in the study and ready to start. Might be not all ready to start on the same day. Patient still in the workup and ready to start next week. So his starting point next week, not today. Okay? So when full inclusion exclusion criteria that included after the diagnosis or after the treatment, suppose that you are following up patient post-operative. So all patients should finish the surgical intervention and then you see afterward. Okay? Make sure that informed consent is signed. Because sometimes the patient fulfill inclusion criteria, but he or she refused to participate in a study. So she is not included. She fulfilled the criteria, she's eligible, but she doesn't like, she doesn't sign. So by signing the consent that the patient agreed to participate. Then allocated group, duration of follow-up, that's what I'm telling you, follow-up time sometimes exceed the study time, doesn't matter. So your study time 2 years, okay, if the patient takes 3 years to see the outcome, don't include that date. So your date you put is the date you put is the recruitment time, not the follow-up time. And then the outcome development. We said you have to put a definition of outcome developed. If the outcome developed cure, mean that the patient have no sign and symptom of the disease for at least 6 weeks post-op. That means my primary outcome is met. Okay? So you have to define clearly what's your end point, mean the outcome you want in your objective. This diagram shows you that when I put the study time between 2013 and 2019, some patients exceed the time, but it's still that's called follow-up time, not the study time. Study time is up above, And this patient can variable. Patient included in early, finish early. Patient included mid, finish mid. Patient included late, they will finish after. So that's the diagram of the study, what happened, the dynamic. Not expect all patient comes on the same day. It takes batches of patients. Similar diagram, but showing you that some patient beyond your study time, it's called follow-up time. This design is randomized prospective study. You can see the sequence now. The total number I recruited is 2,500. There is 2,000 patients excluded because the exclusion criteria is there. So after that, the patient fulfill the inclusion criteria, end up in 590 patients. Included mean, before included mean they signed the included criteria and signed informed consent. After signing informed consent, now I start to randomization. So I cannot do randomization in the top numbers. No, I have to filter this number, let the patient meet inclusion exclusion criteria, and then randomize them after signing the consent. Maybe here you can see 41 patients declined to participate. They do not sign the informed consent. Those patients signed the informed consent, that's the final number, and start to randomization. Now, look at the zero time now. Zero time because I'm starting to treat now. So I cannot say the zero time from the time I started. No, the time when the patient ready to start treatment. After filtering, randomization, and then now look at this patient allocated to the treatment arm. That's called zero time. And then follow up the patient on the treatment phases. Here, sign the consent. Look at this title now. Long-term esophageal and respiratory outcome in children with esophageal atresia and tracheoesophageal fistula. What do you think the design should match this title? Or maybe consider this is your objective and you ask me, what design helped me to finish this one? He said long-term esophageal and respiratory outcome. That means it's a prospective study. It's a prognostic study. He liked to know the outcome, long outcome. So looks like he's doing prognostic cohort study. Look at the outcome after surgical procedure. Now I can say I need to follow up this patient for 6 months after the procedure. So I have to now design is going to match the title, match the idea. It's a prospective study. Here is not randomization because the patient already have one procedure. Okay, I'd like to see what's going to happen to this patient have the procedure after this intervention after 6 months. So it's kind of prospective study, prognostic study, follow up the patient after the procedure to see 6 months or 1 year. Look at the second title here. Population-based longitudinal study, follow-up care for breast cancer survivor. Same. Now this longitudinal study, I can make the design now from this idea. I want to do prospective. I get patient already diagnosed with breast cancer, having surgery or having medical therapy, follow up them on time to see what happens. So I need to do prospective. Here is not going to be randomized. It's prospective follow-up study or prospective cohort study to see what happened. Maybe I can divide the patient on old age, young age, stages of the patient, and so on. But this title gives you the hint of what design expected or what's the best design match your research question. Usually in, this is not related, but anyway, usually in cancer patients, the follow-up, you need at least 5 years. Cancer patient, to know the outcome, you need at least 5 years. So here, the the breast cancer or any cancer follow-up, when you said longitudinal study, you need a good 5 years to see, because some patient you can see in this step down, some patient you can lose patient over time, but after 5 years, now you're reporting the final number, what you call it, survivor. So survivor rate is meaning the last number survived at the end of enough follow-up time. Enough follow-up time being reported in 5-year block. So I cannot say I have 100 patient survival, but this look at the 100 patient survival, that's at 2 years, is not enough follow-up time. At 5 years, the survivor 20 patients. So survival rate is, I can say, 10% survival rate. So usually in cancer patient, follow-up time usually 5 years. That's why longitudinal study mostly with this kind of disease. Look at this title here, outcome of at 3 months after planned cesarean section versus vaginal delivery. So he wants to do longitudinal study, but he wants to limit that endpoint 3 months. So the patient who delivered by normal delivery or cesarean section, I'd like to follow up the patient, the baby, for 3 months and see what happened. So this kind of randomized study after delivery. So have 2 arms here. One arm is normal delivery, one arm is cesarean, and then follow up 3 months. So look at this title, and you can go in detail how you implement this title. I'm going to finish. I think I have to finish here because of the time. But you have, as I mentioned, sample size for randomized study, randomization, comparable start, follow up, and so on. Right. Any question? We have second session. No, there's a big chunk. Right. If we have a second session next week or the week after, I can give you the more detail about this. Right. Any question?
Thank you. They might need to have one more session with you, sort of a discussion. How do you feel about this?
It's okay with me. I can give him a half. I mean, we left about 5-6 slides more.
Okay.
And we'd like to see some questions.
Yeah, because I want to see what did they grasp, if they have these, like concepts in their mind, make sure they have it. So maybe after Eid we can have like an interactive session. You complete the lecture that we stopped at now,
sure.
and then have more questions.
Inshallah.
طيب دكتور أبو سيف، كان عندك سؤال كنت بدأت تسألني وأنا اضطريت أرد على التليفون.
Dr. Ahmed, my question is kind of about the case control study. Sometimes most of what we talk about case control we go to retrospective. But you see case control prospective or cohort retrospective. How can I use this in a useful way? يعني?
والله شوف يعني all this design depends on the research question. يعني أنت الريسيرش question أو الأوبجكتيف هو اللي بيحدد how you're going to implement. If the research question something take long time to develop or something you're going to look at back on time, you choose the design case control retrospective. Suppose I like to review my procedure. You're doing surgery. I like to review my last 2 years procedure to see what happened. I don't know what complication, but maybe infection, maybe bleeding, maybe anything could happen. So I did not put any specific disease. That I do what I call it cohort retrospective. So I review all my chart in retrospective manner without defining what outcome. I just in general like to see what happened. But suppose I'm looking for specific outcome. I want to know infection. Why I'm having high infection rate? Then infection is your endpoint. And now review case control. All the cases infected, I have to review down to see why the infection happened. Is it due to sterilization, no antibiotic prophylactic, or due to no antibiotic after, or due to the patient's behavior or attitude? Many things could lead to infection.
Clear.
So the research question is the key point, and then the design will come after. Don't choose the design difficult for you. Sometimes you said, oh, I like to do prospective. Okay, you need to finish your residency next year. Are you gonna do 2 years? No. So choose the design applicable to your situation. I know most of you resident, at the end of the training, you need to finish your paper. But don't finish it coincidence with your exam panic. Most of you guys, he said, oh, 1 year, I have enough time. And then in the last 6 months, he's panicked because of his membership exam. So, doctor, please, I want to finish this research because I have exam, I'm busy. So please choose a design, match your purpose, match your time allowed for your research.
Okay.
طيب دكتور احمد الله يعطيك العافيه. I think دكتوره دانيا كثير.
يلا باي.
اي الله يعطيك العافيه. Thank you so much. دكتوره هند.
ايوه موجوده معاكم.
طيب
مرحبا بالدكتوره دانيا اكيد، وشكرا دكتور احمد والله ما قصرت.
اهلا وسهلا. خلاص انا اطلع من الشاشه.
والله you can اذا دكتوره دانيا doesn't mind you can stay.
لا انا عندي اشياء ثانيه والله. انا عندي على الخط الان يمكن 6 7 بيشن منتصلين وانا جالس وكله يبغى يخلص اليوم.
ايوه
الناس تسمع حكايه الحظر فبنك حتى البيشنت الان دكتور بسرعه قبل الحظر ابغى شيء يعني الله يعين عليهم. طيب سلام.
تسلم والله. طيب دكتوره دانيا معانا.
السلام عليكم كيفكم؟
عليكم السلام. Thank you very much والله for your time. I really appreciate this. Dr. Dania is not only a colleague, close friend. She's an excellent physician in her field. She's so good with her patients. I have tried this personally. She's an assistant professor at King Saud bin Abdulaziz University for Health Sciences, Reproductive Endocrine and Infertility, IVF, minimally invasive gynecologic surgery, obstetric and gynae consultant. When it comes to research, she has lots of papers. She likes to help residents and trainees to do studies and research and so on. And because of her heavy involvement in the research, she joined as a director of the Research Service Administration in the Research Center at the King Fahd Medical City. And she's a chairperson also of the Medical Forms Subcommittee at KFMC and chairperson of the REI Fellowship Program at KFMC. So we are very happy to have you. You can go ahead.
Thank you. Can I know the audience are residents, right?
Residents at levels وفي maybe some fellows. يعني دكتور أبو سيف, he will be moderating the session in terms of questions. Okay. He is a chief fellow. He's our chief.
No, I don't like it to be boring. I would like it to be a bit more interactive. I have an hour, right?
Yeah, you have an hour. ويا ريت والله interactive. It will be very nice if you can.
No, I like to know what is their background, if they understand, if they want me to elaborate more, because writing a proposal is the most important thing in the research, as you know. Yeah.
And we are also honored to have some residents from UAE, training programs ophthalmology من الإمارات as well.
Can you see my screen?
Yes, we can see it.
Okay.
If you want to put slideshow.